this computer. All right. Good afternoon, ladies and gentlemen, engineers and esteemed students of engineering profession. This afternoon, we are happy to have our presenter, Dr. Lilian Njagi, medical doctor, infectious diseases specialist at Nairobi University. So, as usual, it's wonderful and an opportunity and a blessing to be able to host this webinars together with Diana Wedanji. So at this moment, I'll just allow my other co-host, Engineer Grace Kagondu, to say something before Engineer Lilian, Dr. Lilian comes in. Engineer?
Okay, thank you very much, Engineer Ndolo. And I want to take this opportunity to welcome all our members and all other engineers watching this webinar this afternoon, to welcome them to this webinar, and which has been put together, of course, by the IEK, the Institute of Engineers of Kenya, as a response to the many requests from the engineers and the general engineering fraternity. I think I would like to take this opportunity first and foremost to appreciate and say thank you very much to Engineer Kathy Munyi, who was the one who actually reached out to Dr. Lilian Njagi, because we asked her to get her as a doctor who can help us host this webinar, and she was able to get us Dr. Lilian Njagi. So thank you very much, Engineer Kathy Munyi, for supporting the IEK. Now, I think I would like to move on quickly to say a few words on behalf of the IEK Council. As you recall, during the AGM of 9th of April 2020, the president of IEK, Engineer Nathaniel Matalanga, launched the COVID-19 CSR initiative of IEK, which we dubbed the IEK COVID-19 Response Fund. And he explained that the aim was to lend our support collectively as a fraternity of engineers in the fight against COVID-19. Now, the reason why we are doing this, number one, is because we want to show our solidarity with Kenyans, our community and our society during this trying time of a very brutal pandemic, a scale which we have never seen before. So it is a time for us to demonstrate to the public that engineers are concerned about the situation and they have taken a stand to take action. We are committing to offering our financial resources and our talents in fighting the scourge. Number two is we also want to create more awareness about IEK and what we stand for. We are about positive impact on society, and we want to have many lives change for the better by our effort and our sacrifice in this particular CSR initiative. Now, I think I would like to just go very briefly about what it is that we want to do in this CSR initiative. And this is based on the suggestions that came from members across the engineering fraternity, including from IEK. Number one, we want to provide personal protective equipment to those in the front line, the medics, the patients, and also our communities. We also want to support by providing fumigation and disinfection services. We want to provide water and clean tanks to those vulnerable communities which do not have access to these facilities. And we also want to provide survival kits for vulnerable families. These survival kits comprise foods and other basic requirements. At the same time, we want to support innovations from our engineering schools. You have all heard in the media that we have got the Kimathi University and also Kenyatta University have been able to innovate some equipment, ventilators, and even sanitizers and other kind of aids that can help in this pandemic, in fighting the pandemic. So we want to reach out to these universities because they are engineering schools and see how we can support them. We are already in contact with the Kenyatta University, and just yesterday I was talking to the group that is at Gearbox who have got a team from University of Nairobi also, and they are working very, very hard in developing ventilators. And actually those ventilators look really good. They look almost as good as the ones we are seeing on the internet. And I think with our support, they should be able to come up with something that can work even for us here in the country and maybe even the rest of Africa. And we also want to support by providing technical assistance, drawing on a very unique talents and skill sets. As you're aware, the government has proposed schools in every county to be isolation centers. These areas will need adequate facilities such as sanitation, safe medical disposal facilities, remodeling of existing buildings, efficient access, among others. So, excuse me. Yeah, so we want to be able to support that. Therefore, we are appealing to all our members to come forward and volunteer their services. A portal has been set up on the IEK website for the COVID-19 CSR, where you can get the M-Pesa pay bill number to send your contribution. The target is to raise 10 million. That is what we are targeting, and that is what the president mentioned in the AGM. And we are proposing to allocate maybe 3 million for PPEs, 1 million for fumigation, sterilization, maybe 3 million for water tanks, and 2.5 million for survival kits, and 0.5 million for logistics. Now, we are requesting you to please send your contributions to M-Pesa pay bill number 976. You can see it there on the screen. 976-295. And the account number will be your membership number and then dash COVID-19, or you can put your name COVID-19. You will see the flyers for the CSR drives on the website and also on the social media platforms. Please help us to share widely and keep tweeting and publicizing. On behalf of Council, I thank you very much to all those who have contributed so far. We have raised, let me tell you the figure, we have raised so much, we have raised 690,520 as of today. I repeat that, 690,520,000 Kenya shillings as of today. And every day we'll be providing updates on the IEK website. So keep tracking and keep following on how much we have raised on a daily basis. And we have also created a meter that will be showing how much we have raised. And the meter is shown there on the screen. So once again, thank you very much to the past and the present council and the secretariat team for the cooperation. And to all of you, may each of you be blessed abundantly as you support us with your contribution. Please support the IK CSR COVID Fund. Thank you very much. So now, Engineer Ndolo, I think that is a contribution. That is the opening remarks I wanted to make. So please take on from there. Thank you.
Thank you so much, Madam Grace. And I would just like to remind those who are not members of engineers institution, that their contribution can be received by just, because they don't have membership number, they can just put their name and write COVID-19, the way it is shown on the screen there. Otherwise, Diana, if you have anything, I would like you to invite our guest now.
Thank you, Engineer Ndolo. Thank you, Engineer Grace, for such a comprehensive welcome note. So at this point, I would want to welcome Dr. Lilian. I can see some council members who are here, like Engineer Lucy is the first VP. I think you'll be speaking after the presentation. So at this point, we would want to welcome Dr. Lilian. You had sent on your questions on the Google form and the concerns that you had that we also shared with her. We really want to know what this COVID-19 is, what it looks like. Is it something that if I get, I can get well? There has been a lot of panic. Nowadays, personally, I don't sneeze at peace because I'll sneeze and think, oh my God, do I have COVID now? So there's a lot of panic going around, and yeah, please address that, and now how it affects us as professionals in this space. Karibu, Dr. Lilian, and thank you for your time. Also, thank you to Engineer Kadhi Munyi for connecting us with you. Karibu. Dr. Lilian? Okay, Ndolo, can you hear me?
Yeah, I can hear you. Dr.
Dr. Lilian? Let me give her a call.
The sound on our side, she's there. Dr. Can you hear us?
Yes. Can you hear me?
Oh, yes, we can hear you.
Yes.
There has, Diana, can you get in touch with the,
Okay, let me give her a call and see what's up.
yeah, and if she has a headset, she can use the headset, maybe because the sound is bouncing and there's an echo. I can hear some echo from her side. Yeah, she's back.
Can you hear me?
Yes, doctor, we can hear you.
Oh, okay, sorry, I could hear you guys quite well.
Right. Now it's it's now your time to give a presentation on the guidelines that we had sent you earlier, and from your professional point of view, also teach us a bit about COVID, or rather SARS-CoV2 and COVID-19, the disease. Welcome, Doctor. You have something to share? I will stop that part. Then you can continue.
Okay. All right. So thank you for having me. Most I'm impressed with the work you're doing from just listening to your introduction.
Doctor, your sound is gone again.
She's muted. I'm trying to unmute her.
She muted herself. She's a co-host. Don't worry.
So,
all right, Doctor, don't.
I did receive your question. Am I muted?
You had
I'm
muted.
not muted from my end.
You had muted yourself, so just.
Oh, really? Okay. Am I still muted? You can hear me?
Yes, yes, yes.
Oh, okay, that's interesting. I didn't mute. Okay, so I'll just go ahead with the presentation then to comprehend. Yeah, but I will cover a few of the ones we can be able to cover in a presentation format. So if you want to interrupt me at any point, you feel free to do so. Yeah, so I'll just move on. So our discussion is on SARS-CoV, COVID-19. And I think one of the first questions I saw is, what is this SARS-CoV and what is COVID-19? It seems there is quite a bit of confusion on what the difference is, and I'll go into that. But before I start, just to tell you what coronaviruses are, because really that's what we are talking about here. And it's a large group of viruses which cause respiratory illnesses. And respiratory, we mean the nose, ears, throat, lungs, which medically we call as upper and lower respiratory system. So coronaviruses are a group of viruses, and there are many other viruses that cause these what we commonly call flus and colds and chest infections. Now, coronaviruses were first isolated in the 1960s, and they are divided into various groups. The 4 groups are the most common, and then below those groups are many, many species. So coronavirus, the one we are discussing, is just one of these. They affect both human beings as well as animals. we'll focus on what we know about coronavirus more epidemic, which is called the global. It didn't become a pandemic. So before then, it was the usual coronaviruses, which cause flus worldwide in temperate areas. Normally, most of us get these coronaviruses from childhood, and keep developing immunity, and we get another variant, but your body then clears it off. And transmission and contact, either direct or indirect. Okay? Now in 2003, there was the outbreak of SARS-CoV, which started in 2002 to 2003, did not spread much beyond China. And since 2004, we haven't had any case of the SARS-CoV, and I'll go a bit more into that. Then in 2012, there was another outbreak of a similar virus, which is called MERS-CoV, and what this stands for is Middle East Respiratory Syndrome Coronavirus. While the SARS-CoV is, we will go into it in more detail. But what we know is that the MERS-CoV, since 2012, we've had a few outbreaks here and there, but in the Middle East, confined to the Middle East. So a few cases, but then they clear off by themselves. So now what is this SARS-CoV, what is SARS-CoV2, and what is COVID-19? So the first outbreak of SARS-CoV was in 2002, ending in 2003, the last case being reported in 2004. And just to tell you what this is, these are the abbreviations, what I've highlighted, given the name: severe acute respiratory syndrome, coronavirus.
Doctor, just a minute. It seems your internet is poor.
Very poor.
You keep on breaking.
Virus itself is a coronavirus, the syndrome, and that's big we see.
Doctor's internet is poor, so we will allow her to come back. She has gone off the radar.
Let me see if I can get her on call.
I think we have a problem. The sound is very poor.
It's yeah, the sound is the network is very bad. Doctor, are you there? You are. Just a minute.
And also the buffering from my end is very loud. I don't know whether you are also hearing the same.
Sorry?
Are you also hearing that buffering?
Not really. From my end, no. Yeah, now I'm hearing it. Can you hear me? I've changed internet, so I'm not sure how that sounds now.
It's better. What internet are you using, Dr.
Safaricom. So I've just
on the phone.
Yeah.
I hope nobody will call you when we are talking.
No. Well, I have changed to a wireless. So then I changed to the phone, which didn't work well. So I've changed back to the wireless, which had gone off. So I hope that will be stable enough.
All right, all right. Then you can now start, you can continue with your slides, please.
Okay, sorry, let me just share the screen once again. So we can go back at that point.
Yeah, but can you start the slides? Start the slides so that
from the beginning.
No. We can see that like make it whole screen, like playing it rather.
Okay. Sorry. That?
Yeah, that way.
Is that better?
That's better.
Okay, but we continue where we left?
Yes.
Okay. So I'll go into what the difference between SARS-CoV2 and COVID-19 is, which is, I think, one of the first questions that was asked. And the word SARS-CoV first came in 2002, the name SARS-CoV, which is the name of the virus which was implicated to have caused the outbreak in China in 2002, 2003, with the last case being documented in 2004, and no case since then. Virus has been designated the name severe acute respiratory syndrome, coronavirus. So the CoV is a short form for coronavirus, an acronym for coronavirus. Then SARS is derived from the word severe, meaning, it gets severe. Acute of sudden onset. Respiratory talks about our lungs, our breathing system. Then syndrome usually talks about a number of symptoms coming all together, not just one symptom, but a number of symptoms presenting, in which case we are initially not sure what is causing. So that's where the word SARS came from. And so it was called the SARS-CoV virus, which caused the SARS-CoV disease outbreak of 2002. This virus was less efficient in its transmission, which explains why it didn't become a pandemic. And it was easier to control and contain because of the less transmission, although there was a higher mortality. Although for now, that's based on the current statistics, but we don't know how this disease will evolve as we are going on. What we know is that the mortality rates approached 10% for the SARS-CoV. For the current COVID, we've been below 5, but looking at the data today, we are at around 6% of mortality. So we are waiting to see how that happens. Now, COVID-19, when we talk about HIV/AIDS, which is the one most people understand, is that AIDS is the illness, the acquired immune deficiency syndrome, which is caused by HIV, which is human immunodeficiency syndrome. So if you think of it like that, you will then understand that COVID is an acronym for now what we are calling the disease, like AIDS. The equivalent of AIDS in this case is COVID, which means coronavirus disease of 2019. And the reason we say that is because, as you've seen, there have been many coronaviruses. There are the coronaviruses which caused the common cold. Then there was the coronavirus which caused the SARS outbreak in 2003. Then there was the coronavirus again, which caused the Middle East respiratory syndrome. Then now there's a new strain of the coronavirus, which scientists had to try and identify what is it. So at first, it was then called severe acute respiratory syndrome, coronavirus 2. And the reason for this is from looking at the genetic makeup and seeing that it had a high resemblance to the SARS-CoV of 2 or 3. So the genetic makeup is still remaining not 100%, but it's very similar, over 90%, a close relative of the SARS outbreak of 2 or 3. So that's why the virus has been given the same name, but with a 2 to show that it's the second one. Okay. Now that is the virus. And then, as early on in January, it was then given the name of 2019 novel coronavirus. Novel, new, so it's a new coronavirus, which was in 2019. Then towards the beginning of March, around there, WHO then decided to coin it coronavirus disease of 2019, to be able to differentiate it from the SARS-CoV disease. So I hope that now clears it. So the disease is then coronavirus disease, which is for 2019, first reported in 2019, November, and the virus causing it is the severe acute respiratory syndrome coronavirus, the second one, to differentiate it from the one of the SARS of 2003, which are similar but a little different. So one is the disease, the other one is the virus causing it. So now we can go to the virus, the SARS-CoV2, causing the COVID disease, or the COVID-19 disease. So what is currently known, first we all know now, it started in Wuhan, China, and the initial cases were linked to the seafood market, which was then closed, sterilized, but then the cases continued to spread. It's caused by the SARS-CoV virus 2, as we have said. By 11th of January, China had already now looked at the genetic sequence and they knew what the virus was. And that's how they were able to link this genetic sequence to the previous SARS, but then say that it's a little different, not exactly the same. Hence, it was given the name SARS-CoV2. So it causes a number of respiratory disease, ranging from very mild to very severe. And by the current statistics, we actually see that 80% of the diseases are mild. Yeah, with now the remaining 20%, some being slightly severe and others, a small percentage, about 4-5% being lethal, leading to death. Okay? And what we know is that serious medical conditions are leading to a high mortality, as well as the elderly. And we know the elderly also come with other serious medical conditions and lowered immunity. What is not known is where it really came from. It is thought that it came from bats. Some scientists are saying that origin may have been from bats, but then it passed on through pangolins and then to humans. But this is not clearly known. Everything is speculation up until now. And it's also not known exactly how easily it spreads between people, although we know it is definitely spreading faster than the SARS-CoV of 2002 and the MERS. Okay? Although for now, the mortality is slightly lower. In terms of spread, it's thought to mostly spread through person to person, the route being first droplet, and we know droplets are the heavy, when you cough, sneeze, or talk, what you spit out, those are heavy droplets that quickly fall to the ground or to any surfaces. And when these droplets get in touch with your mucous membranes, and the mucous membranes are inside your mouth, inside your nose, your eyes. So yes, you can get the transmission into you through your eyes or anywhere where there is moisture. The period of infectivity is not known. And by that, what we mean is we don't know how early someone starts infecting others. But what has been seen is that people who don't have any symptoms have been known to spread. In fact, there was a current study which showed that about 25 to 30% of the people spreading don't even know they have the infection. Yeah? So it's not quite known. That is something that is still evolving. It's also not quite clear how long people continue transmitting even after that, especially because of the tests we are doing. Does it mean when they turn negative is when the person has stopped spreading, or they stop spreading even when the test is still positive? The risk of transmission varies by the type and the duration of exposure. And by the type, what we mean is if there is a high amount of secretions and one gets into contact with it, then you're more likely to get the infection. Then the preventive measures that have been used, for example, someone with a mask is least likely to transmit as opposed to someone without a mask. Then there are individual factors, and here we are looking at how high is the viral content, the viral load. We call it the amount of the virus that the person has in secretions, where if these secretions have a very low viral load, and that we can only tell by measuring from the lab, then they are more likely to be infectious. For environmental contamination, it's not quite known how long SARS-CoV2 can persist on surfaces. what is known is that all the other coronaviruses can persist on the surface for 6 to 9 hours, which is quite long. So if this follows the same trend, then it means our surfaces can retain this virus for that long, and so it can continue transmitting for that long. In terms of animal contact, what has been shown is that humans are now transmitting the infection to their pets, and mostly it is cats. And when cats get infected, they become symptomatic, but there hasn't been any proven case of now cats infecting humans again, but it's known that humans are infecting their pets, especially cats. From experiments, it's also showing that it's possible to infect dogs, but dogs are remaining asymptomatic. And there's also evidence that humans can infect dogs, but we don't know anything about domestic animals then transmitting to humans. So when someone has an infection, then it's to keep their pets away from them. Otherwise, they're also going to be infected, and especially for cats, which become symptomatic. These are the symptoms we mostly expect. 90% of the patients develop fever, but not everybody who has COVID will have fever. So you'll still have a small proportion with the infection and without fever. Some even developing severe disease and developing fever much later than what you expect. But of all the symptoms, it's the most common symptom, fever. Then this followed by fatigue, which really is a word to mean feeling tired, dry cough. Most people develop poor appetite, then muscle aches, difficulty in breathing, then they start producing sputum. And these symptoms I've arranged in order of how frequently they occur. How do we confirm the infection with those symptoms? I mean, anybody who develops those symptoms and is known or knows themselves to have had contact with somebody who is infected, or if one is a health or if one has traveled recently, then a test needs to be done. And the tests we are doing are currently, they're called molecular tests, which look really at the, for this virus, it's called RNA. For our cells, what our cells have is the DNA, the deoxynucleic acid. But for the viruses, it's an RNA, ribonucleic acid. So what the molecular tests, which are reverse transcriptional polymerase chain reaction tests, they look at the ribonucleic acids of the virus. And a positive test will generally confirm that someone has the infection. We have reported a few false positives. They are possible. Then false negatives have also been documented, but what has been seen with the false negatives is that they come from secretions. When we get secretions from the upper airway, for example, the nose, that's when you're more likely to get negative tests. So what we recommend is if somebody has symptoms and you highly suspect that they have coronavirus, they need to repeat the test, but with a different sample. And the sample should preferably be taken from the lower airway, that's closer to the lungs as opposed to the upper airway, which is the nose and the throat. 90% of mild cases, when you repeat the test after a duration of treatment or even without treatment, by day 12, most tests are turning negative, which for us could mean that they are clearing infection by day 12. However, what has been known is that most severe cases are staying positive for longer, some even up to 3 weeks, but most of the severe cases have been known to recover by the 3rd week, with the mild cases, most of them having recovered latest within the 2nd week. So the other thing we are not sure of is that when you do this test and it's positive, say 2 weeks after treatment, does it necessarily mean someone is infectious? And it doesn't necessarily mean that, because molecular methods are looking at the nucleic acid, and it can be a dead organism. You're just picking the genetic material from a dead organism. So it may not necessarily mean that if a test is positive, that someone is still infectious. The only way to tell if someone is infectious is to do a culture, which means you try and grow the virus, but we are currently not doing that because, again, of course, there is the risk of growing the virus and it reinfecting the people who are handling it. But then also in this emergency setup, culturing a virus takes quite some time. So we'd rather use the resources in looking at tests where we can quickly get the results at a lower risk. So using the test, then we may not use it so much to monitor response to treatment. What we are using to monitor response to treatment is how the person is responding. That said, we still repeat the tests as the patient is undergoing treatment to see at what point it is turning negative. Now, someone asked how long it's taking to get the results. It ranges anywhere from 2 hours to 1 week. That looks a very broad range. But the molecular test itself gives results within 2 hours. The issue is the logistics between sample collection. For example, if someone is out of Nairobi with the transportation of the sample, then, you know, we've just started doing the test in the various labs. So the national lab is quite overwhelmed, but they are trying their best. So at the beginning, it was taking as long as a week. The time limits are getting shorter and shorter as more and more labs are now starting to do the test. We know now KEMRI has gotten funding. The university is also starting to do the test. So the timings will get shorter as we go along. Someone asked the role of community testing. It's very important. As you've seen, South Africa has already started doing community testing because that's the only way we can tell how many cases do we actually have. For example, in Kenya, when we say we have 200 cases, are we sure that is all we have? Remember, we've said 20 to 30% of patients may have the infection but not and transmit it, but they are not symptomatic. So it is possible that we have people out there in the community who don't have the infection, who have the infection, but they don't have any symptoms. So we are not able to tell the actual number of people so that we can be able to tell how much community transmission is ongoing. So it is important, but we are limited by the resources. For now, the closest to community test is the contact tracing that you have heard of. And contact tracing has been done for years, especially in regards to HIV and other all infectious diseases. Basically, when there's an outbreak, you want to get anybody who's been in contact with that person because they're the ones who are likely to have gotten the infection and to spread it to other people. So for now, for every case identified, we are looking for the people who have been in contact with that person and do the test. That said, the government is also doing some level of community testing as the resources allow, you know, as funding comes in. As we wait and see, of course, if there's funding, then community testing will be done as we go along. Other tests which are still undergoing study, as we said, molecular tests are quite expensive, but it's the best available right now. There are other tests, like, you know, the HIV test, which we normally do, which we look for antibodies, which is antibodies against the infection. So there is a test which has been developed looking at antibodies against the infection, and it's been approved by the FDA to be used by only specific in America, which have been validated to use it. But they are using it, for example, in patients who are symptomatic and then this PCR is negative. For some cases, it's been shown to help in improving the diagnosis. But then again, the antibodies don't rise until, say, around 10 days. So, and it's mostly useful to tell us whether someone has had a past infection, because the timeline at which we can be able to tell someone has had an acute infection, sometimes they are not symptomatic. And by the time they are symptomatic, the specific antibody that tells us whether someone has just gotten the infection starts to come down as they start developing immunity. So we can only be able to tell if someone has developed a past infection. That said, these tests are being improved to aid in diagnosing the acute infection, but for now they can only be used together with the PCRs. As we go ahead, they will be used for community testing, to be able to ask how many people have gotten the infection and actually managed it. This test will also be able to tell us long-term, are we developing full sustainable immunity to the coronavirus, which currently we are not sure. There are thoughts that people are developing immunity, but that has not been said yet, has not been known yet. But these antibody tests are the ones which will be able to guide us as the disease evolves. Then there are also like the rapid test, the HIV test you can do for yourself through a small prick without the blood having to be taken to the labs. There have been such tests which have been developed, but those have not been approved. So they are not, WHO has not recommended them for use yet. So management, I look at management in two respects. There is home management, and then there is hospital management. So for now, we recommend home management mild infections. And by mild infections, we mean people who are asymptomatic, and some of these will be identified through contact tracing. When somebody with an infection, given a list of the people they've been in contact with, once these people are tested and they are found to be positive, but they don't have any symptoms, or they have mild symptoms, where the mild symptoms are fever, cough, with or without muscle aches, but without dyspnea. Dyspnea is difficulty in breathing. So as long as someone does not have difficulty in breathing, they are basically stable, then you manage them the same way you manage a common cold. The difference, there is need for quarantine, the isolation, because you need to prevent these people from transmitting the virus to other people around them, which is why we are saying people go home but stay, even within their own homes, they isolate themselves. And while they are also supposed to monitor for clinical deterioration, where one of the signs of deterioration is any difficulty in breathing or symptoms which, instead of improving, they start getting worse. And these people will need hospitalization. Anybody who from the onset presents with difficulty in breathing or clinically unwell, the elderly who have other illnesses, diabetes, hypertension, cancers, those require hospitalizations. Those are considered as patients with severe infection. The main thing is appropriate infection control. In the hospital, we give supportive care, that is oxygen, ventilatory support for respiratory distress syndrome if it's there, fluids for dehydration. We give painkillers, to manage the fever and the pain. So basically for these infections, it's a supportive care. There's no medication that is currently approved. I know people have been hearing about and have been buying hydroxychloroquine, but it's the information we have now is from what we call observational studies and case reports. And those are usually the lower level of evidence. Not to say that it's not good evidence, but to be able to approve any form of therapy for use going forward, what you need are clinical trials. And these are properly set clinical trials, which are testing patients on this treatment vis-a-vis patients not on this treatment, and looking at the two different groups and monitoring, and even using different combinations to be able to tell which of these drugs can really be said to be working. So for now, there are many therapies which have been shown from observation, just as people are trying, but there is none that is approved. So what is currently recommended is, as we take care of patients, you're allowed to try some of the medications that have been shown to maybe work. But we recommend now, even as you enroll patients, you're also enrolling them into a clinical trial, so they can contribute to the database that is helping us to decide in the long term which medications can we say can be able to work for COVID-19. So unfortunately, even with all the excitement, hydroxychloroquine is just one of the potential drugs, not a confirmed drug. There are many others, but none of them have been confirmed up until now. Other investigational approaches, one of the questions you asked about were vaccines. How far are we? Are we anywhere close to deciding we have a vaccine? And there are many vaccine candidates being tested right now. The closest, which is about to undergo human studies, is in the United States, but we cannot be able to tell anything about it as of now. Vaccines take a while to go through all the processes, but of course, even this is a pandemic, the processes are being fastened, but there's only so much you can do. So for now, no, we don't have any vaccine that we can say can work against COVID-19. There have been papers about BCG, which is the immunization we all get, especially in African countries, to prevent us from TB. And just a caution is that this BCG immunization, even if we say it prevents us from TB, it's severe forms of TB. It doesn't mean if someone is given the vaccine, they will never develop TB. They will just likely not develop very severe forms of TB. And there have been a few papers here and there which have come out trying to show that the BCG, people who've been vaccinated are least likely to develop severe disease. But again, this is still observational, nothing that has been tested to confirm. What we know and have always known about the BCG vaccination is that it induces an immune response, which does not only work against the bacteria that causes TB, but this immune response can also extend to protect you against other bacterial and viral infections, but not to protect you 100%. So for now, how impactful it is in preventing us from getting COVID is unknown. And as you can see, in Africa, we are already getting we have a number of patients now with COVID. And we do know, like in Kenya, almost every child, adult has received the BCG vaccination, but we are still getting cases. So this again is something that is still being studied, not confirmed. Now, prevention, the best way to prevent the illness, and not just this one, any infectious disease, is to avoid being exposed to the infection in the first place. And that this is where all the precautions we are taking come in handy. Then, of course, you cannot be able to prevent yourself 100%, but there are everyday preventive actions that you can take. For example, the hand washing, either with water or hand-based hand rub, soap, water. Then social distancing, which is about 2 feet of social distancing. You know, the closer you get to someone who has the infection, the more likely you are to get infected. As we know, the mode that is confirmed is droplets. We know droplets are heavy, so they quickly drop to the floor. They are not able to go beyond 6 feet, which is about 2 meters, which is why we are advised to stay more than 2 meters. However, you know, WHO has cautioned of the possibility of transmission in the air, which means there might be a few small particles that hang in the air and don't drop to the floor. But what I'll say about this, when you look at the studies that looked at it, it's not really from observational. It was studies which were designed specifically to just see how these droplets are moving and staying in the air. So it was largely experimental, but we don't know exactly how is this happening in, you know, real life. So it's a caution, and we all know that, you know, particles may then be remaining in the air for a bit longer than just, you know, the few minutes where, you know, we'd say if we keep to about 6 feet away, then you're completely safe. We don't know that. That is still something that's being studied. Then there are the personal protective equipment, which we need to use as needed, and we'll go a bit more into that. So you asked, part of the PPEs is masks, and one of the questions is, what are the masks for? Who should use it? Which masks should we use, and how should we use them? And what we know about masks is that They protect whoever is wearing them from airborne particles and from liquid contaminating the face. And we'll go into each mask and who should wear them. Now, different countries are having different policies on the use of masks. And, you know, the decision to use masks even in public places is first because there are these thoughts that, you know, it's not only droplet, but it could be airborne. Then let's face it, in countries like our own, where social distancing may not work too well, people still have to go to markets, people have to use public transport means, then you might want to encourage them to wear masks. So for now, every country is coming up with its own policies. WHO has its own policies and of course has allowed the various countries to come up with their own policies. But what you need to know is that, you know, there are people who are asymptomatic, who are